Good morning, everyone. Welcome to the second annual online event for the Heartland State of Diabetes. One of the blessings of COVID is that it forced us to move to a virtual setting for this event. And although we miss seeing everyone in person and realize that the collaboration between you isn't as strong, we do think this provides a wonderful opportunity for us to squeeze this into your very busy day and then allow you to listen to more speakers from across the country and then have this as a recording to be able to share with other teammates. Just to kind of review with you again, the Heartland states include Indiana, Ohio, Kentucky, Kansas, Missouri, Nebraska, Iowa, and South Dakota. We welcome all of you here from those states and from around the country. We are thrilled to have you join us for such an important event. I am Mary Delaney. I am the managing partner of the Alira Group Vital Incite division, and I'm happy to be your MC today. Before we start, I want to make sure I take time to thank our wonderful sponsors of this event, and that includes Lilly Diabetes, Novo Nordisk, JM Family Enterprises, the Alira Group, Kentucky Diabetes Prevention and Control Program, Hancock Health, Northwind Pharmaceutical, TrueRx Health Strategies, Unified Group, and the Tennessee Department of Health. Without their support, we would not be able to provide such an incredible resource to all of you. So thank you so much to our sponsors. So let's start talking about even why it's worth us spending some time on this today. I don't know if you're aware, but in the United States, every 23 seconds, someone is diagnosed with diabetes. 1 in 10 Americans have diabetes today. That is over 37 million people in the United States that have diabetes. Over 96 million adults are also pre-diabetic, which is a precursor to diabetes. And unfortunately, 81% of those don't even know they have it. So the problem is if you don't know that you are already at risk for diabetes, you're likely not making any changes to help lessen the chances that you become a type 2 diabetic. With that, the American Diabetes Association has offered a free online risk test, and you'll see that down below at diabetes.org/risk tests. That is of no cost. You can share that link with all of your employees, loved ones, etc., and it helps them realize if they are at risk for diabetes and therefore making the necessary changes, getting the help they need to try to prevent any movement or progression in the disease. And why do we want to really work on reducing the impact of diabetes? Well, diabetes leads us at much higher risk for many serious health problems, including heart disease, kidney failure, amputation, stroke, and even blindness. Given that, we really want to understand what are the primary factors, the root cause that is fueling this crisis in America and now even across the world. To start with, social determinants are very critical. Poverty with lack of access to adequate health care, lack of access to health insurance, therefore creating a barrier to health care, poor access to nutritious foods, outdoor space for healthy exercise, and even access to medications are all fueling the problem of poor health leading to diabetes. There are biological factors, including age, genetics, and ethnicity that lead for increased incidence of diabetes. And then, of course, lifestyle factors. Unhealthy foods come up again, and physical inactivity, which all leads to obesity. So what can we do then to create anything better, and why is this important? Well, we need to realize, and I'm sure as many of the individuals here that are benefit advisors or employers of health plans understand that the annual healthcare cost for a person diagnosed with diabetes is 2.3 times higher than a person without the disease. And 1 in 7 healthcare dollars are spent treating diabetes and its complications. So what does the ADA want to do about that? Well, our mission with the ADA is to cure diabetes, to prevent diabetes, especially type 2, where we realize that there are more opportunities currently, but even in the future, type 1, and then to improve the lives of those that are living with diabetes. Our focus at the ADA is really fourfold. Increase risk awareness, such as that risk test that we've just talked about. Fund innovative research to bring you the next best thing so we can improve outcomes. You'll hear about that more today, especially in our breakout sessions. improve medical care, and then engage the community, including employers, so we can drive better outcomes. So today, we're really excited to share with you a panel discussion on the care pathways for controlling and preventing diabetes. So without further ado, I am really excited then to bring our panelists forward and allow them to introduce themselves, and then allow you to learn more about, some of the discussion points that we're going to have today. So panelists, do you mind turning on your cameras? So if you could start off and introduce yourself going from left to right on the screen. So Dr. Wierum, do you mind starting off and letting us know a little bit about yourself and your background?
Sure. Thanks for having us, by the way, and inviting me on. I'm an endocrinologist practicing in Nashville, Tennessee. I sort of trained in the Southern Trio, undergrad at Duke, Medical School, UNC, and then Vanderbilt for my residency and fellowship. When I started, we only had 2 classes of drugs for diabetes. We now have 13. I taught at the University of Tennessee as a core faculty member of the residency program for about 10 years, and then I moved into private practice. I have also been the director of 2 diabetes centers, one at Baptist Hospital in Nashville, now St. Thomas Midtown, and then also the director of Heritage Medical Associates Diabetes Center, and I am a practicing physician with Heritage Medical Associates here in Nashville, Tennessee, as I speak.
Great, thank you so much. Megan, do you mind going next?
Yeah, so my name is Meghan Haftman. I completed my Doctor of Pharmacy degree at Southwestern Oklahoma State University in 2013. I've then went on to complete a PGY1 residency at Ascension Via Christi Hospitals in Wichita, Kansas, and a PGY2 residency in ambulatory care in St. Louis with the St. Louis College of Pharmacy in St. Louis, Missouri. I'm a board certified ambulatory care pharmacist, as well as a certified diabetes care and education specialist. I currently work as an ambulatory care pharmacist in Wichita, Kansas. So a little thing that's kind of unique about my position as a pharmacist where I work is that I work under a collaborative practice agreement with the providers at my clinics, which allows me to make changes to their medication. So start, stop, change for different chronic disease states. And I would say a majority of the patients that I take care of either have diabetes or prediabetes.
Wonderful, thank you so much. Dr. Benneyworth.
Good morning, good afternoon. Thank you for having me. It's a good opportunity to present with today. So I'm Brian Benneyworth. I'm an executive medical director at Eli Lilly and Company in our Global Diabetes Medical Affairs unit. I am I used to be a practicing pediatric intensive care physician at Riley Hospital for Children here in Indianapolis. I did my training at the University of Michigan and medical school at the University of Tennessee. In addition to being an intensive care provider, I'm a health service researcher. And so that means I'm interested mostly in how the health system functions and ways to improve the healthcare delivery of the therapies that are developed either in pharmaceutical companies or other technologies. I've been out of practice now for several years, but continue to do research within this area. I'm also a type 1 diabetic.
Great, thank you so much. And then Elizabeth Barton, do you mind closing up?
Yeah, I am Liz Barton. I'm a type 1 diabetic. I've been diabetic for 19 years. I currently work as a pediatric CVICU nurse. My husband, Michael, and I have 3 young kids, 6, 4, and then 5 months. So we're very busy. My brother is also a type 1 diabetic. I was diagnosed as a young teenager, so I've really been able to have quite a wide range of life experiences as a diabetic, navigating challenges of pregnancy, entering the workforce, working as a nurse, and just life in general, living with diabetes.
Incredible. So I'm really excited about our panelists today, because as you can tell, they come from a variety of different backgrounds. And I think our conversation is going to be very stimulating, and other suggestions and ideas, and bring some light to all of us and maybe what we need to consider. So to start off with, if I could, I'm going to pick on our 2 type 1 diabetics, because I think we need to start off and hear more about what it's like to be really living with diabetes. Have you, and as we're working with employers and carriers, et cetera, benefit advisors, we'd like to know if you've ever seen any gaps in benefits that could be improved upon that may help people improve their diabetes management. Dr. Benneyworth, you want to kick us off?
Yeah, so I mean, we've got two panelists today that with type 1 diabetes who are relatively uniquely qualified to manage the disease. And I'll speak for myself, but it can be a challenge on a day-to-day basis. You get frustrated managing insulin, you get frustrated with your blood glucose measurements. Some days are better than others. And if I have trouble with it, I'm sure every person who has to manage the disease has trouble with it, even more so. So anything we can do to make managing this disease easier is helpful. It is challenging with commercial insurance to understand what the benefits are, and they change. They can change on an annual basis. Where your CGM coverage comes from, whether that's pharmacy or durable medical, whether you need to get mail-in prescriptions, mail or not. Getting testing on a regular basis. These are all challenges that, because of the unclear nature of health benefits, it's often hard to keep track. And I know what the system is and how it functions, and it's still hard.
Liz, have you ever experienced anything like that?
Yeah, definitely. As a nurse, I feel, and as a type 1 diabetic, just concerned for people that don't know kind of how to manage their care and how to fight for what they want. I definitely had some struggles even while I was pregnant, just getting my diabetes supplies and how critical that CGM was during the time that I was pregnant. But a lot of trouble, and I knew who to talk to and who to go to get it, but still had trouble. So that does worry me kind of for other people that may not know. And like Dr. Benneyworth had mentioned, just getting the supplies and how do you get them, and the constant change of where is it coming from? Where's my supply that's going to be here in 3 months coming from? And am I going to have trouble? And when can I start to get those supplies or start reaching out? Because sometimes there is a delay, and it's unfortunate, as we all know, it's a chronic disease that's not going to go away in 3 months when we need another set of supplies. So just the constant advocating for yourself is challenging. And just, to close up, it is for sure concerning for people that don't have the background like we might have.
Not only not the background, but the stamina. I mean, both of you, I know when I got to meet you both, we're talking about how much effort it took for you as clinicians to be able to get what you needed. I think, Elizabeth, you talked about your CGM and the argument you had to have because they didn't want to fill it too early. And you were explaining to them that you were going to have a gap in care then. And just explain that experience just so that maybe the employers can understand where some of the barriers are.
Sure. Well, it just seems like insurance doesn't love to cover things until that 90 days hits, or maybe your 89 days. And then you have 2 days of shipping possibly, or more. So that's kind of just definitely a struggle. But it does create a lot of struggles, just because the CGM, you get a little bit reliant on it, and going back to finger pokes, and you can't check your blood sugar every 5 minutes to know where your blood sugar is at or where you're going. So the CGM has been critical in maintaining my diabetes care.
Dr. Benneyworth, I wanted to go back to you because you mentioned putting both, like some of your stuff comes from the medical plan, some comes from the PBM. Why is that a problem? Can you explain that?
Well, first of all, it's not all coming from the same place on the same schedule at the same time. And so you're constantly worrying, am I going to get the CGM in time? Am I going to get my insulin pump supplies in time? But even little things, and Elizabeth was alluding to it, when my insurance switched from moving the CGM supplies from the medical benefit to the pharmacy benefit, I had to get another letter from my physician. Well, my physician, I wasn't supposed to see my doctor for another month. And so they were a little hesitant at first to write another prescription because it was almost close to the year. I knew how to advocate, so it was fine, and I got it worked through, but somebody else maybe not. And so just little things like that make it challenging with access.
So I've seen Meghan nod her head a bit. Meghan, anything, or Dr. Wierum, you want to share?
I was just thinking about all the patients and all the hoops that they have to jump through, and how, I have to advocate for them a lot, and they would not be able to get the supplies that they need. They don't know how to get through. So if it's difficult for somebody like Dr. Benneyworth and like Liz to get it, that know how to navigate the system, how much more difficult it is for our patients that don't know how to navigate the system.
And I'll just clarify some abbreviations since I'm a stickler there. CGM, of course, is continuous glucose monitors. These are little sensors people wear, and when you don't have one, it's a little bit like trying to drive with your eyes closed, and you can only stick your finger so many times. So it's a big, big gap in your personal ability to control your blood sugar if you can't get those supplies. And it's a very big frustration for patients when they have local pharmacies, and then what we call PBM, which has been mentioned, which is the pharmacy benefits manager, which is this sort of nebulous big business that mails you your prescriptions, and you hope they arrive, and you hope they got the scripts, and you hope it was approved, and you hope there wasn't a glitch. And so it's really, I think, nerve-wracking for someone like Brian and Liz, who are just hoping that the system works so that they can get things that they need to live their everyday life normally.
So it amazes me when I listen to this story, and I was able to speak to each of you before this, but understanding that there's that many things that you deal with on a regular basis, I would not have been aware of. And it really helped me understand why, when sometimes employers would say, so why are my people not willing to be compliant? Why are they not willing to do this? You understand if they even have a little less health literacy than you two, which the majority of the country will, it's really it puts them at a great risk to not be compliant, because they're not going to be able to navigate this. So speaking of navigation and health literacy, let's talk a little bit on prevention of type 2 diabetes. Now that is an area where, if we could move the needle on preventing some of the incident rate of type 2 diabetes, but employers are really trying to figure out what they can do more, better, what resources, et cetera. Meghan, you had some pretty inspiring stories of how you manage these. Do you mind starting us off with that?
Sure, absolutely. I think when we're talking about type 2 diabetes, either prevention or delaying progression of type 2 diabetes, those are the most important things that we can do. I think about several of my patients that have been diagnosed off an A1C just at a random health fair screening, or maybe an annual, something like that, and they have an A1C of 9 or 10, and they don't feel bad. They don't have any symptoms. And so I think really in terms of prevention or being more aggressive in diabetes treatment, making sure that we're testing for A1Cs earlier and more appropriately. The ADA recently updated their screening guidelines for diabetes. So they now recommend screening all adults, even without risk factors, at age 35 instead of 45. And I think that really says a lot, because we're seeing more and more younger patients that come in and have type 2 diabetes. And so I think, hopefully this is maybe identification of pre-diabetes more, that 81% of the population that doesn't even know that they have pre-diabetes. And I think one factor to help patients really be successful in the prevention or delay progression is really access to those education materials. So education, coaches, different diabetes educators, I have patients that I've seen with an A1C that were newly diagnosed of like 14. And again, we talk about those CGM devices. This patient didn't want to add insulin to their regimen. And so I was like, okay, we can do like 2 or 3 weeks, but then we got to reevaluate. We can't go this long. So what I really focus on when I'm talking with my patients and doing a lot of education is what I call the 3 M's. So meals, movement, and medications. And I really focus on how those are 3 different pillars, and they're all important. You can't fix it with just one thing all the time, but it's really important to do all of those. And it's kind of surprising to find how many people will make some different changes to avoid medications or avoid adding medications to their regimen. So this patient that I'm thinking of specifically, we went over lifestyle modifications, which they had never had, basically didn't have the information about it. And they came back 4 weeks later, and were able to get a CGM, and almost all of their glucose readings were within goal. And that was just with like one oral medication, and then again, those lifestyle modifications. And I really think we've seen over the last few years that providing patients with that education and then the CGM that helps to provide that immediate biofeedback really helps drive home, I think, different points of what foods affect your blood sugar, what activities affect your blood sugar, and it empowers the patient to have the opportunity to make more changes for a positive outcome. So, I really think that just enforces that patients need both the knowledge and the tools to be successful in treatment of their diabetes or prevention of diabetes. And so the sooner we're able to get them knowledge and treatment, the better outcomes hopefully that we'll have. And sooner interventions, I think, also, equate to slower progression of diabetes or total prevention of diabetes. And overall, that's going to be less cost of care potentially to the patient, and better improving of the patient's quality of life. So I think sometimes, we can look very short-term focused, like what's in the next 3 months or whatever, but really switching to that long-term focus. How do we delay progression of diabetes, prevent diabetes? And I think access to both knowledge and then those tools. I'd love to see the CGM access, expanded for patients, definitely everyone with diabetes. Maybe even, I think patients with prediabetes could benefit from that as well, to see how some of those glucose spikes and things affect them.
It's great. And I know that I've heard many stories about the CGMs, and someone in the chat said they're so expensive. So I think that is removing that barrier, that financial barrier would be critical. Someone asked if CGMs can be used for let me look at that chat. For GDM, I don't know what GDM is.
For gestational diabetes. And the answer is yes, we use it regularly and all the time, particularly on the patients who require insulin.
Perfect. Yeah, thank you. And then Meghan, you brought up in our conversation to prepare for this, how many times you've had patients come in who felt totally fine, and you got an A1C and to find out they were at 9, and they weren't even aware that they could feel better than that. Is that the case?
Yeah, I think, there are sometimes people that come in with an A1C of 9 or 10, and they're like, well, I don't feel any different. And then we control their blood sugars and they're like, oh, I do feel better actually now. Or maybe just different things like that. So I think, again, just the unawareness. And, at 9 or 10, we're definitely in that range where we're potentially causing complications and things like that, especially depending on how long that goes unchecked. So I think that's a big thing too, whatever we can do to identify those patients earlier. And again, give them that knowledge of, they may not feel bad, but that doesn't mean that we're not having those complications like we talked about earlier, heart, your kidneys, all of those different things.
Very good. Anyone else have anything to add? Dr. Wierum?
You want me to go forward on the whole prevention weight issue at this point?
Why not? Let's go. Let's dive in. I think that's the hot topic for the next year for sure.
Well, I think so. And I got a couple of caveats. First of all, to my knowledge, there is no diabetes medicine, or actually any medicine on the market, that is FDA approved for diabetes prevention right now. In fact, it's very difficult for patients to have access to medicines that will have a significant impact on their insulin resistance, their body weight, or their appetite. And all of these, of course, are contributing to the epidemic of obesity, which is driving the epidemic of diabetes in the country. So this is a huge problem, very difficult to wrap our arms around it or to pay for it as a nation. So what I'm going to do is organize my comments as follows. Because there's no diabetes medicines approved for prevention, I'm going to talk about medicines that can help weight, but they're not FDA approved in that regard to prevent diabetes. And then what I'll do is point out, well, what are those medicines and how much can they help weight? And what are other things that can help weight in terms of helping patients who are struggling with that as a major risk factor for diabetes? So first and foremost, we've had 2 major advances in drug classes over the last 17 years. I'll take the more recent one first. Sodium glucose transport inhibitors. These are drugs called SGLT2 inhibitors that cause people to urinate out glucose, and as a result, everyone who takes them loses some weight because they get a discount. Calories are going out in their urine that they would otherwise stay in the body. These drugs not only can help our patients lose weight, but they have wonderful additional benefits. They can cause weight loss, I've already mentioned, but they can decrease the risk of cardiovascular death in patients with existing cardiovascular disease. They can decrease the risk of heart failure admissions to the hospital in patients with known heart failure, regardless of their ejection fraction, and also prevent the death of those patients. And then more recently, they've been shown to decrease the progression of renal dysfunction, which is a major issue for diabetes patients. As an added benefit, they don't cause hypoglycemia. So these drugs are not yet approved for diabetes prevention. They are being tested, but again, that's a possibility for the future. The next major class, which I would say is probably the number one exciting class for patients with type 2 diabetes, again, this doesn't apply for type 1, are GLP-1 drugs. And so they're glucagon-like peptide number 1 agonists. They hit a receptor. These are normal hormones in the body that we are actually enhancing by injecting a analog or a similar molecule to the normal hormone. And they also cause weight loss. In fact, much more significant weight loss than any class of drugs that we've ever had for diabetes or for weight loss in general. So they have proven to be the most effective, powerful weight loss medications on the planet today. So obviously patients are interested in this. They also cause a decrease in heart attack, strokes, and death. Specifically, they've shown a particular decrease in strokes, which is very hard to do. Even aspirin has been wiped off the map as a general recommendation because it caused more bleeding than stroke prevention in many people. So we have a huge benefit here in decreasing some misery as well as death in patients who are at risk for diabetes or who have diabetes. The most exciting new class is a combination hormone, or it's a hormone agonist that hits 2 receptors instead of 1. It hits the GLP-1 receptor, which we've already talked about, and I'll mention those drugs in a second, but it also hits what's called the GIP receptor. Now, this gets very technical, but the bottom line is you got one drug that does 2 things, and the weight loss for that drug has been even more remarkable, but it has not yet been proven to decrease the cardiovascular events like the GLP drugs, but it is being tested. So now let's be specific, because if you're an employer, you want to know, well, okay, what are these fancy new classes and drugs? What does it actually mean for my patients? What would they want? There's a once-a-day injectable. It is called Victoza. It's for diabetes, but it also has a counterpart, the exact same drug called Saxenda that's approved for weight loss. So you can use it for diabetes, or you actually can use it for weight loss. Not FDA approved for diabetes prevention, but you can see that might actually happen. That's one of them. The next GLP-1 receptor agonist drug is called Ozempic. It actually is an injectable once a week instead of once a day. It has an oral component or a counterpart called Rybelsus. They're the same exact drug for diabetes. Very effective, also cause weight loss. And they have a counterpart that is FDA approved for weight loss called Wegovy. So now you have Ozempic and Rybelsus for diabetes, same exact molecule, Wegovy, for weight loss. Obviously, potential for preventing diabetes there, but has not been FDA approved for that indication. The last name I will throw out for you is the most recent and probably has been getting a lot of press lately. It's called Mounjaro. Mounjaro is the only drug that is actually FDA approved to hit 2 receptors, and it hits the GLP-1 and the GIP receptor. And for reasons that are still being investigated, this drug that hits both these receptors has even more significant weight loss than any of the GLP-1 drugs alone. In fact, it's been so powerful that it has been up to 25 pounds of weight loss in patients with diabetes, and it has also been in trials. It is not FDA approved, but it is fast-tracked for possible approval for weight loss, and they've seen trials where patients lost 22.5% of their body weight. So you put that into the computer, and that means that a 200-pound individual would lose 10%, that's 20 pounds, 20%, that would be 40 pounds. So a 200-pound person would lose up to 42 to 44 pounds of weight if it ends up being approved for weight loss. We also have gastric sleeve and gastric bypass surgery, which are wonderful ways in which patients can lose weight. These have been proven to prevent diabetes, they're not necessarily FDA approved. They're procedures that we know have been proven to decrease the incidence of diabetes and actually take diabetes and put it in remission in many situations. So that is my best review of the classes of drugs that have shown to help people to lose weight, which then can theoretically help them to prevent diabetes. And we hope that these are going to become more available. I will put in one other plug, and that is that whenever you're treating chronic disease, and we've heard from Brian and Liz in particular about supplies and access and medication availability and cost, this is a chronic disease. To have people have a huge deductible doesn't make sense. To have high copays for drugs that are life-sustaining does not make sense. You've got to think of a model where people are going to ration their medicines if you don't allow them to have that. In fact, there was a recent article that talked about patients, there's actually an ADA thing where about, how many millions of patients actually ration their diabetes medicines and their insulin because they can't afford it, or they ran out and their copay is too high, or they had a deductible. I think that could be solved by getting together as an employee or as an insurance company and saying, maybe chronic disease should be under a different model. So I will stop there and let others comment.
Thank you. I appreciate that. One of the comments that came up in this week's discussion clinically was that if someone comes to the doctor for their wellness exam and they have diabetes, they suddenly get another fee for that wellness exam. So some people may not be willing to speak up if they think they're not feeling correctly when they go in for a physical. So all of that coding around, believe it or not, that's the coding that then they can be charged more for a physical and then have to pay that out of pocket. We have found also that people will not get A1C testing because if that's something they have to pay for, they'll avoid it. Anyone else have any more comments around this? Now, there's a lot of talk about these medications. They're very expensive. So kind of thoughts on how you can maybe balance that with some other lifestyle improvements. So hopefully they're not dependent upon these drugs for life. Meghan, I think you've had some of those conversations with the movement, right? I'm going to pick on you.
Yeah, so I mean, I think utilizing these medications is very important, and honestly has given some people that, especially with the weight loss, that have never seen weight loss, it's given them hope and things like that. But I think it needs to go in combination as much as we can with those other lifestyle modifications that we talk about. So I think it helps. Some of these new medications, specifically the GLP-1 class is what I'm thinking of, helps. I always tell my patient it helps to reinforce it, or negatively reinforces our bad habits. So, when we overeat, when we eat the wrong thing, we can see more side effects with that. So I think it does kind of, from that perspective, the thing with it being with obesity itself is a chronic disease. And so management of that, I think it will be interesting to see how that goes forward in the next several years, just because it's such a quickly evolving field and so many patients are struggling with it. And then that really does feed into prediabetes and type 2 diabetes.
Dr. Benneyworth, I thought maybe you were going to add something there.
Well, I just was going to pick up on something Dr. Wierum said. That I think that the important aspect here is that the health system and the delivery of care, especially with chronic disease, for people with chronic diseases, is complicated. And it's not limited to the interaction between the person with the chronic disease and their healthcare provider. And that includes, people like Dr. Wierum and even Meghan, who are providing that kind of comprehensive care. And I think it's important for the employers to understand that they're not just handing their employees a book and saying, "Oh yeah, here's your opportunities." They are part of the healthcare system. They're providing access, and it doesn't let anybody else in the healthcare system off the hook in terms of making things more accessible. But that recognition that they're part of the healthcare system and understanding what they can do, whether that's structuring plan designs, whether it's making it clear to the employees what the benefits are, or even structuring reduced barriers, and even measuring the outcomes for the interventions that they have offered for their employees, they're part of the system, and so can take an opportunity to help improve it.
No, that's great. Thank you. I'm going to kind of pivot a bit, but when we're talking about opportunities and how do we provide all the opportunities necessary, wanted to see if anyone could comment about other advancements that have been made other than medications. We know where everyone's very excited about these medications. It's funny, even just a year later, how much everyone has said the differences with the CGM monitoring and what that has brought to people. What else is out there, and what do employers need to consider offering or making sure they don't have barriers to in order to help with success of diabetes care in general? Liz, do you mind starting off?
Sure. I was diagnosed 13 years ago, and I started with syringes and vials of insulin, which now seems pretty ancient to where we are. I use a pump and CGM that talk to each other, which is fabulous. Just as not only a healthcare provider, just working in the ICU, you don't have a lot of time to sit down for yourself. Well, at home, I could almost argue I'm a little bit busier with 3 young kids. So I like that it takes a little bit of burden off of my load to kind of make some adjustments and not have to micromanage as close as I typically would have prior to using a CGM and a pump that kind of work together. So I think there's some really great advancements out there, and it sounds like there's a lot coming down the road too, which is exciting. As a type 1 diabetic, I mean, you can eat the same thing every day, do the same thing every day, and your blood sugar is going to be different. So I'm really looking forward to seeing what the future holds for different advancements.
It gives me the chills to even think about what it was like when we were first diagnosed to what we're talking about today. It is almost like we're in a totally different world in what we're dealing with. And I do think that there's amazing stuff coming. We just have to remove those barriers, don't we?
That's right.
Anyone else have anything to add?
Well, Mary, I think that the other thing, this is always the silver lining on COVID, is it has taught us different ways to provide care to patients. I'll let Dr. Wierum speak for himself, but I know that I'm now participate in more virtual visits with my providers than I do in-person visits. They're much easier to access. Being able to do lab testing, without having to go to a center. Some of these things are available at home, and I think it's changed our mindset about how we deliver medical care. And I hope that this continues because I think there's some opportunities both to improve the value and therefore reducing some of the cost of providing care. So.
That's great.
I definitely want to chime in there because it is, I think, a no-brainer. If there's one great thing that came out of this pandemic, it taught me that not only can we do virtual care, but it is the absolute wave of the future. And anybody who's thinking about limiting it and not allowing it to happen, I understand there's potential abuses, but that's very rare and very unlikely. But the ability for me to connect with folks at home, especially if they're older and don't want to drive, if the weather is bad, I have people traveling 2 hours to see me, and sometimes I don't need to do anything to them physically. I just need to speak with them face to face, and virtual care should be included in every insurance plan going forward. I want to put in a huge plug for that. I think it's going to eventually cut your costs, and not only that, it's going to save your patients time, lost work, gas money. I mean, I could go on and on. So please continue virtual care. I will put in a plug for CGM for anyone who takes insulin. So that's all type 1s, but it's also patients with type 2, which we've had trouble getting CGM covered occasionally. But anybody who's taking a drug that is the #1 drug to put you in the emergency room in this country, with maybe the exception of blood thinners for bleeding, but hypoglycemia is certainly #1 or 2, and it's insulin. And you can definitely cut that cost by allowing people to be able to see their blood sugar with a CGM.
Those are great points. Can I just, before we move on
go ahead.
to, oh my gosh, I just lost what your point was before this. what did you say before the CGM?
The virtual and
The virtual visits.
yeah.
Yeah. So sorry, I want to make sure because employers are buying outside services for virtual care and then complaining that they're paying for virtual visits from the providers. And that needs to stop. We don't need an extra outside company providing virtual access. Pay the current providers, give them the right things, because you have the relationship, and that fragmentation of care is not going to lead us down a good path. So sorry, I just couldn't bite my tongue on that one. So go ahead. I didn't mean to interrupt you.
Now, I only had two other things, a plug for Tresiba for all type 1s. This is a particular long-acting 48-hour insulin for patients who have type 1 diabetes. If you can't be on a pump or you don't want to be on a pump, Tresiba is our only insulin for type 1s. You will save an admission for diabetic ketoacidosis for the college kid who goes to sleep and forgets his insulin. He's in DKA by morning if he's on any other insulin but Tresiba. And so it's one of those things where the 48-hour insulin for people not on a pump, if you're type 1. And then pumps and CGM for type 1s, I think that Brian and Liz would absolutely say you have to have that ability. We now can close that loop and have the pump actually be controlled somewhat by the sensor. It's changing how we manage type 1 diabetes. Last thing I'll put out for employers is a screening A1C. Certainly for anyone with a BMI, which is a measure of weight versus height, that's over 27. And then if you have family history, you could argue annual A1C for everyone, given that 1/3 of our country has prediabetes or diabetes. 1 out of 3. So you got a 1 out of 3. What other tests do you all pay for that has a 1 out of 3 chance of coming back positive? It just, it's a no-brainer. So those are my things for plugs for insurance coverage.
That's great. Someone in the chat just asked about, we talked about the medications for obesity. What about CGMs for treating obesity too and raising awareness related to that? And Meghan, I'm going to ask you to kick it off because I know you had some great examples that you shared with me.
Yeah, and most of my patients that I see that have CGMs that don't necessarily have type 2 diabetes are at least in that pre-diabetes category. But I have had a lot of patients pay for the CGM out of pocket because it's important to them and they want to monitor it. And it really does show them those spikes that they don't even think about having, or the foods they eat that they're like, I didn't think this would do anything. So, and I think that again goes along with obviously prevention, because then they can make those changes early on with that biofeedback that they get from their sensor, really to understand what's happening. And I think that encourages them to make more changes. I don't want to say it's kind of like a game, but people that get more information can do more with that information. I get so excited about CGMs because this is information we didn't have for such a long time on multiple people. Even as practitioners, knowing what's happening throughout the whole day by you either scanning 3 times a day or having a Dexcom or whatever, provides us so much more information about what's happening postparentally or whatever overnight that we didn't have before when we had 3 different test spots. So I think that's really, I would hope to see CGMs at least approved for more easily for patients with type 2 diabetes, and maybe even that pre-diabetes range for that very motivated patient for progression. I think there's been some discussion about using it for patients that don't have any that just have obesity and have no changes in their blood sugar or anything. Whether that would be beneficial, maybe not. I think that's a little bit more of a gray area. But I do get excited to see CGMs more in those patients with type 2 diabetes, with them getting it approved more easily. I just think in a year or 2 years, it's going to be an essential tool for anyone that has type 2 diabetes.
So I've had professionals explain to me that they have had patients who would be on their CGMs and realize that, oh, this isn't actually a healthy meal. It never occurred to them. So it help raises health awareness. And I do think that intermittently that could be of value. Does anyone have anything negative to say about a CGM being used intermittently? I just want to make sure from the clinical perspective. Okay. Because I know the issue is always cost, but if you think about the cost of obesity over time, it definitely would be nice if we could help people with their literacy on that. Very good. I thought I heard Meghan say something about people learning on those drugs when they eat. I know, sorry, Meghan, but you made this comment. I didn't want to forget to go back to it about people learning that they've eaten the wrong thing when they're on these meds. What does that mean?
Yeah, so, the way that these medications work, they work on that gut hormone that delays gastric emptying. So if they're eating too much or the wrong thing, a high fat or a high carb meal, they're more likely to have those negative side effects of like nausea and vomiting. And so, it's kind of a negative reinforcement of those bad habits. I think for a lot of people, it just cuts their appetite in half or just away altogether. And so it also, I think, helps them be more mindful of, are they really hungry? Listening more to some of those cues, like, am I really hungry versus am I just eating because it's mealtime? So, and I think that that's part of the obesity epidemic, is things like that have just become natural to us. We have a lot less active jobs now. We eat breakfast, lunch, and dinner, whether or not we've been really active or whatever. And so I think that these medications just are going to have helped a lot of my patients that didn't even realize they were eating when they weren't hungry, or didn't even realize, that healthy meal, but actually it's very high in carbs or very high in fat. And so when we try to eat that on these medications, we have those side effects. So.
Thank you. I think that's good to know, because I'll be honest with you, most of us lay people thought, wow, what a wonder drug. How can I go and eat as much as I want and then just take this pill and it's just gone from my body and I don't gain weight? We didn't realize there was actually biofeedback taking place to kind of make you more aware.
If only that was the case.
I know. Then we would pay $2,000 a month for that all the time. Anyone else want to add anything to that conversation?
I will mention very briefly I think it is definitely a curiosity and potentially helpful for people with prediabetes and obesity to see what their blood sugar is doing. But with employers looking at cost cutting, I wouldn't be upset if that is not a covered service. Now, why? Because you can actually wear a CGM for a couple of weeks for about $75 cash. That's about how much people pay on Starbucks in 2 weeks if they buy a $5 drink every day. I mean, I think that for things that are more like, I want to know what it is for a couple of weeks because I'm curious and it may help me to change my behavior. I think that's different than the people who are on insulin, who I'm going to say, I'll go to the mat for coverage. People who are, on type 1, I'll go to the mat for coverage. I'm a little bit more liberal in terms of how I would approach an insurance company or an employer in terms of coverage for the other categories, because I think they could be done intermittently and it wouldn't be as huge a burden cost-wise because they're not essential.
That's a good point. When we talked about virtual care, I just want to verify, if someone's on a CGM, is the provider able to see their CGM results in that conversation? So can they go online and be able to see that and provide feedback? Can you guys, someone enlighten us to that?
I'll take it if no one else will, but I know that that Megan and Liz and Brian know the answer. Yeah, we can see it. They have to give us permission. And once they give us permission, I can go online. And in fact, I surprised a patient of mine once because I was going to call him anyway. And I called him and I said, "What did you have for lunch?" And he goes, "What do you mean?" And I was like, "I can see your peak." He's like, "How can you see that?" And he's like, "Because you gave me permission." So I can literally go online and see what he's doing.
Liz, with being pregnant and a type 1, explain to us a little bit what that looks like so an employer can understand maybe what the specific concerns are, needs, or why we have to make sure we give access to the right things.
Sure. So just during pregnancy, your blood sugars need to be in a very tight range, ideally. So I wasn't able to use like the closed loop. It was more just kind of micromanaging my blood sugars during that time. And that kind of looked like a lot of visits with my endocrinologist and a lot of communication, sometimes 2-3 times a week to make changes. And with the CGM, her being able to have access to that and my pump records without having to go to the office and being able to send those virtual, we would check in, at least twice a week, especially towards kind of the beginning and real close to the end, but really throughout the whole is just very important. Obviously, there's a lot of complications that can happen to you as a diabetic personally, and then add another growing person to that, there can be some challenges. So just the importance of that. And, I think that ties in the pump, the CGM, and just access to virtual care being very important, especially during pregnancy, but daily life as well. Just you want people to feel good, and you feel good when your blood sugars are good. And it's very important to me. And I'm sure other people want to feel that same way too.
That's great. That was really helpful to understand. So in closing, I think that Liz just gave us her closing. We're never going to forget that and how important it is. Anyone else have anything you want to kind of close with, statements that you want employers to really walk away with?
Well, I'll bite. I think the biggest thing is, as I mentioned earlier, that employers and the access to healthcare that they're providing is part of the system. So thinking about ways that the employers can work with their employees, that they understand their benefits, and even that the employers can help their employees and their health costs be accountable to achieving outcomes and improving care. They're part of the system, and so stepping up and engaging and taking ownership of that part is important.
And from what I'm hearing, employers may need, because I consult with employers, so what would I ask them to do? Probably even be very open to asking their diabetics about where there's confusion, because they may think it's all played out really well in their handbook and it's really clear, and not
right.
even
The 300-page handbook. Right? Yeah. I think having those discussions with their employees and to understand what challenges they are facing, what things can be helpful. And as Dr. Wierum was mentioned, thinking about opportunities for screening and really ways to put systems of care in place so that the patients aren't just left out on their own. Make the right thing to do the easy thing to do is really one way to think about it.
Very good. Who's next?
Yeah, I think just like what everyone said, I think making it easier for the tools that they need is really what we need to do. I think there's so many barriers right now to the tools that are needed because there have been advancements and whatnot, that any way that employers and health plans can make it easier for them to get those necessary tools is going to, prevention and delaying progression. Those are big things for the overall care of the patient.
Dr. Wierum?
First, I should apologize to Dr. Benneyworth. He's called me Dr. Wierum, and I've been calling him Brian. So I respect.
That's fine.
I honor your credentials. I did not mean to be too familiar in that regard, but
No.
in any case, I will just reiterate my quick list, and that is that virtual visits need to stay. CGM for all patients on insulin. Obviously, that's type 1s, but also type 2s. Tracebas for all type 1s not on a pump. And type 1 should certainly have access to pump and sensor. And then screening A1Cs for anyone at risk, certainly, but that has turned into be 1/3 of the country. So I think screening annual A1Cs, I've had that denied even for patients who were clearly significantly overweight, and the insurance company says, we're not paying for that. And I just don't understand. I mean, I think that's something you want to know. One hospitalization or one ER visit for high blood sugar is going to cover the A1Cs for everyone on your plan for a year, or remove all the cost savings you might have had by not covering that simple screening test. And it doesn't have to be fasting. Whenever they show up, they can get that blood test and diagnose diabetes with it, or prediabetes.
So thank you guys so much. I think the big takeaway for me is and I'm hoping employers have heard it, people are not just deliberately non-compliant and don't want to take care of themselves. It is really hard to do this correctly. And we've got a lot of great resources on the market and resources between providers that we can do a much better job. So hopefully we can move it forward and we can start proving that if we give them those, that actually they don't cost multiples more to be a when a diabetic doesn't cost much more than someone without the disease, because we can control it much more effectively. So you guys have been absolutely excellent. Thank you so much for your time today. I really appreciate it. At this point, we're going to move on and go through our breakout session. So thank you very much.
Thank you.
Thanks.
Thank you.
So next we are going to move into our breakout sessions, and I want to just quickly explain what those are so you can go to the room that is most important for you. These will all be recorded though, so you'll have these the access through the ADA, and you'll be able to share these with other people. So first of all, breakout room 1 will be the connected care with Isaac Smith. He's a clinical pharmacist at Eli Lilly. He's going to talk about what's next in the technology. So we just heard about all these other wonderful things that are taking place. This will tell us what's next and kind of really talk about more of that closed loop communication strategies that are taking place. Then room 2, we have Joel Huntgate from Regional Hospital talking about prevention, control, and management, really more moving towards those lifestyle approaches and how you can integrate some of that within your employer environment to be able to create better strategies. Room 3 is the impact employers have on leveraging the ADA resources. So the ADA has a lot of wonderful free resources for employers. Where you're going to have Molly Doerr go through examples of how employers have leveraged these resources and the impact that it can have and how you may be able to use that. And then last but not least, we have room 4. That is our emergency preparedness. So unfortunately, we've had more and more natural disasters taking place between hurricanes, floods, et cetera, and some that have even hit in the recent months, the Heartland team that we have been speaking with. So that group with Elaine Carson and Kathleen Stanley will talk about how to have the appropriate packages ready for these emergencies. So at this point, we're going to break off into those rooms, and then I'll see you back in about 10-15 minutes.